More assessment of the human, both adult and child, from a more physical dysfunction perspective. So coordination, this should be quite familiar to you. We've gone over this pretty extensively already, but just to refresh, coordination is our ability to use different parts of the body smoothly and efficiently. So incoordination could consist of errors in rate and rhythm, and this is evaluated by the speed and consistencies of movement. Irregularity could be slowness or an arrhythmic sort of movement. You also will be looking at force of movement and amplitude, and this is evaluated by the consistency of the movement intensity. It could be improper force control leading to overshooting or undershooting. And you also might be looking at inaccuracies in coordination with accuracy. So this is evaluated by the ability to strike a target, such as, with the finger, nose, again, sort of looking at that overshooting, undershooting component. So what are some ways that you might document, evaluate and document coordination? We've gone through a lot of this, your functional assessment and observation. What are you seeing them doing during a functional task? Thinking top-down approach. Or are you using a bottom-up approach and using more formalized screenings or evaluations immediately? So finger, nose, nose, finger opposition, rapidly alternating movements, or you're maybe using a standardized assessment such as the 9-hole peg test, the Minnesota manual dexterity test, or the Purdue pegboard, which you'll have the opportunity to do in class. Now think about, how do you document, and how does your assessment of coordination relate to occupational performance? So being very specific, you assessed these things, they were not able to complete these things impacted them how? And going back to that idea of top-down, if you are using a top-down approach, so for example, using occupation to assess coordination, and you note some level of impairment during accuracy or force of movement, then you might do a more formalized assessment or standardized assessment to really pinpoint what is the why behind why you're observing what you're observing. Sensation, again, this should also be pretty familiar. We have spent a fair amount of time on this. So sensation, the absent or diminished physical feeling or perception, and this could include light touch, differentiating between sharp and dull, proprioception, kinesthesia, temperature, pain, stereognosis. So you should, for this lab, have your coordination and sensation kits so that you are able to practice them and see how they work in real time. So some functional assessments and observation, again, that top-down approach, using occupation to observe how the client's sensation is, or more formalized testing or assessments. Hot-cold differentiation, identifying light touch and localization, sharp-dull, stereognosis, proprioception, and then your standardized assessment, and you'll have the opportunity to practice with the monofilaments. And this is very helpful for light touch localization, 2-point discrimination across the dermatones. So your dermatone testing is very important. And going back to, how do you document this? How does this impaired sensation inhibit function? How does it relate to the client's ability to engage in occupational performance? So it always goes back to the why. You will, so looking at the assessment of edema, you will practice with the volumeter today, but there are some other methods outside of using the volumeter for looking and documenting edema. So edema, swelling caused by excess fluid trapped in the body tissue, primarily seen in arms, hands, legs, ankles, and feet. There are 2 types of edema. There is pitting and there is non-pitting edema. So pitting edema, if you look at the picture on this slide, when you press a finger into the swelling, does it leave an indentation? If it does, that is called pitting edema. If it does not, it is non-pitting edema. And those are two technical terms, pitting and non-pitting. You also have lymphedema, and this is a buildup of excess lymph fluid within if the lymph system is blocked or damaged. And it's important to know what the underlying causes of the edema is. Is there an underlying disease process such as congestive heart failure or CHF? Is it kidney disease? Is there a DVT or a deep vein thrombosis? Is there cellulitis, which is an infection? Is it related to medication? Is it pregnancy related? Because all of those are really going to determine how it's treated and how you're managing that edema. So how do you evaluate and document? Use your functional assessment and observation. And this is less about occupational performance, but really just using your eyes on. And identifying, is this a sock line or is this problematic edema? So if it is a sock line, which most of us get with that minimal pressure of an object against our body, if it resolves within 10, 15, 30 minutes, it's not really much of a concern. But if that edema does not reduce or go away after a certain amount of time, you need to do more observation to identify what is the cause of this edema and why. And then what is your intervention going to be based on that observation? So some questions you might ask yourself when you see edema: is it new onset? If it's new onset, it could be related to a deep vein thrombosis or DVT. Is it warm to the touch? Is it tender? Again, relating back to DVT or infection, cellulitis. Is it bilateral or unilateral? So is it on one or both sides of the body? And is it pitting or non-pitting edema? And then how pitting or non-pitting is, or how pitting is it? And we'll talk about that in another slide. And then you have your formal screens or formal assessments using a water volumeter, which you'll have the opportunity to practice, using girth measurements with a tape measure, and doing a pitting edema assessment based on the depth and duration of the indentation. So what is pitting edema? Grade 0, no clinical edema, nothing concerning. Grade 1, slight pitting, or 2 millimeter depth with no visible distortion and it rebounds immediately. So if you press on the swelling, it immediately resolves. Grade 2, somewhat deeper with no readily detectable distortion, and it does rebound after 15 seconds or so. So when you press on the edema, there's a little bit of an indent, but then it resolves within 15 minutes. Grade 3, noticeably more, takes longer. Grade 4, much more distorted depth, and it takes more than 30 seconds for the rebound effect. Skin. Crucial, 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 crucial. We're always looking at skin on all of our clients. We play a critical role in preventing skin compromise. We're always doing education. If you do education with your client, make sure you're documenting that. What do you educate them on? Doing frequent skin checks. So if you have somebody who has a sensory impairment that you have identified earlier on, so you've done maybe sharp dull, you've done localization, you've done whatever sensory testing that you've done, and you've identified that they have a sensory impairment. You are making sure that you're educating them on skin checks. So if this is somebody who has limited sensation on their bottom, limited sensation on their feet, you name the area of limited sensation, you are encouraging them to do frequent skin checks, and you're also teaching them the importance of pressure relief. So if you have a client who has limited sensation in their hands, and because they don't feel their hands very well, their hands just rest in one position for a prolonged period of time, they the possibility of pressure ulcer does increase. So we want to make sure that we're encouraging them to do skin checks, and then why it's important to do pressure reliefs. We're teaching them maybe on adaptive equipment, such as a long-handled mirror to assist with those skin checks. So if they can't see the bottoms of their feet or between their toes or their backside, giving them a long-handled mirror so that they can do their own skin checks. Wound care is a higher level skill, and that is certainly a practice area for OTs. For those OTs who do have a strong stomach, but likely you will come across wounds in your career. So we won't necessarily stage the wounds, but we can have an understanding of what those stages mean. So stage 1, if there is a skin integrity concern or issue, a stage 1 would be the skin is intact with some sort of non-blanchable erythema. So a persistent red or discolored area of skin that does not turn white when pressed. This could signal early damage to the underlying tissue due to lack of blood flow. So that could be a bruise, that could be a blister. Do not ever pop or touch somebody's blister, because you don't know how deep the wound underneath that blister goes. And that blister, that skin, is in fact protecting the wound. Stage 2, partial thickness involving the epidermis and dermis. Stage 3, full thickness that extends to the subcutaneous tissue but does not cross the fascia. And stage 4, full thickness extending through the fascia, through considerable tissue, and there might be involvement of muscle, bone, tendon, or joint. And skin compromise can happen so fast. So it is so critical that we perform education as soon as possible. The next video is a picture of wounds. So if you have a gentler stomach, or just be trigger warned of what you're going to see next. So stage 1, the erythema, non-blanchable erythema, so the bruising, redness, blister. Stage 2, a little bit deeper, partial thickness. Stage 3, full thickness, loss of skin to the subcu tissue, but it doesn't cross the fascia. Stage 4, full thickness extending through the fascia and with considerable damage. So our role, super critical. We have the ability to do all of these things. There is specialized training that goes along with this, but this is something that we can do, and I encourage you all, if it's an area of interest, to definitely talk with a nurse or go to wound care training. This is an area that I have always been interested in, and I was part of a wound care team and found it very meaningful to really work with the team on skin and reducing skin compromise. And just a little added bonus, if a client, so this could be child, adult, across the spectrum, across the lifespan, if they're in the hospital and they acquire a pressure ulcer, called a HAPU, hospital acquired pressure ulcer, acquired in the hospital, insurance won't pay for that. So it's very important that we do education and that we do training and that we're always looking at skin. So we have the ability to apply dressings to wounds. We can do removal of sutures and wound closure strips. We monitor. We can do mechanical debridement with training. We can do sharp debridement. We can apply different applications. We can do different applications of different wound healing medications. We can do physical agent modalities for wounds. All of this does come with specialized training. So just keeping that in mind, but highly encourage it. It's very cool. And to do more education on wound care or wounds if you're working in a hospital. So documentation. Document. Can't say this enough. On your evaluation, if you're working with anyone, outpatient, home therapy, hospital, rehab, look at skin. I don't care who the client is. Look at their heels, look at their elbows, look at the back of their head, look at their bottom, look at everything and document it. Because what did I just say? If the client develops a hospital acquired pressure ulcer, we then have to pay for it, or the hospital has to pay for it. So you need to document it and show nursing what you've seen so they can document it, because we want to make sure that we're not paying for something that did not happen at our facility. So what do you document? You are documenting if it's redness, if it's irritation, if it's shiny, if it's discolored, if there's a blister, if it's whatever, all of the things that you observe, you're going to document. You want to consider if this is a peripheral nervous system condition or a central nervous system condition and how that impacts skin. So if this is, let's say, spinal cord injury, stroke, brain injury, where there is likely sensation loss because of an upper motor neuron condition versus a peripheral nervous condition like neuropathy, like the mechanism of skin and skin breakdown and skin integrity could look a little bit different. So you want to make sure that you're understanding that and then making your observations based on those things. We talked about pressure, where it can happen. Always look at those places, doing skin checks, and then making sure that you understand what pressure injuries actually are. Ulcers, sores, decubitus ulcers, bed sores, skin breakdown. Those are all types of pressure injuries. The Braden scale, this is an interdisciplinary scale that is used across all interprofessional disciplines, a standardized assessment to evaluate somebody's risk of developing a pressure injury. It evaluates their sensory perception, moisture, activity, mobility, nutrition, and friction and shear. And putting that together, and the lower the score, the higher the risk of potentially having a pressure injury. So that is sensory perception, moisture, activity, mobility, nutrition, friction, shear. Adding those numbers together to generate a total score. The lower the number, the higher the risk. We play a direct role in this because we can work with somebody who has sensory perception deficits. So if they are unable to feel or have some sort of sensory impairment, we can make modifications and adaptations. If they're unable to respond to directions or communicate in terms of them needing to be rolled or turned, or if they're having pain or if they're having sensory impairments, we can work directly with that. Moisture, making sure that our clients are dry. Activity, making sure our clients get up. Mobility, making sure our clients get up and move. Nutrition, working with the dietitian and a nutrition team. And friction and shear, making sure that we're not dragging our clients up the bed, in the bed, dragging their bottoms across the bed, in the chair, dragging them across a slide/bump board. So we have lots and lots of roles in the prevention of skin compromise. Pain, vital sign. Pain, vital sign. Pain, vital sign. You need to assess pain with all of your clients. You need to document pain with all of your clients. If you didn't document it, you didn't ask about pain. If you didn't rate their pain, you didn't ask about it, it didn't happen. So you need to document on pain. Pain is super subjective, but it is very real to our clients. So we need to be very mindful of how we manage and ask about pain. Lots of reasons why people could have pain. Here is a laundry list of reasons. And there could be reasons that are not on here that people have pain. So how might you evaluate pain? Observation and interview. Are you having pain? Somebody is nonverbal, looking at their facial expressions, grimacing, etc. If somebody says they have a 10 out of 10, and you say, okay, good, and you keep on going, that's not great, because they've just acknowledged they have a 10 out of 10, which according to the Wong-Baker or the numeric rating scale, that is the worst of the worst pain. And if you didn't do anything or you just said, okay, good, like that's not acknowledging that somebody might be in an excruciating amount of pain. And not always will somebody's facial expressions match or their behavior match the number that they are reporting. So they might say they're at a 10 out of 10, but they're laughing. Everybody's way of managing pain is going to be very different. So we need to be very mindful of how we are dealing with and managing pain. The other thing to consider is, because pain can be subjective, we don't necessarily want to perseverate on somebody's pain. So if they are having pain, where is it? Does anything make it worse? Does anything make it better? How do you sort of redirect, offering pain medication, offering other modalities, interventions to manage the pain? Change of position, ice, heat, whatever, and documenting what it is that you did. So you did an assignment on the Socrates. So this should look pretty familiar. So every time you're doing documentation, you should be documenting on these things. Where is it? When does it happen? What does it feel like? Does it radiate? What makes it better? How long does it last? When does it happen? Does anything make it worse? Does anything make it better? And how does it limit the client? And then documenting 1 out of 10 or 0 out of 10. 0 being absolutely no pain, 10 being the worst pain you've ever had in your life, and you need to go to the emergency room. Some other things to consider when documenting pain: is this chronic or is this acute? So going back to your Socrates, what is the onset? The management of chronic pain is going to look maybe a little bit different from somebody who has acute new onset pain. The quality of pain is determined by the client describing the pain. So it could be sharp, it could be dull, it could be throbbing, it could be tender, it could be shooting. Insert verb or adjective. How intense is it? 0 out of 10. Where is it? And if they can't tell you, can they point to it? And then again, how does it impact occupational performance? Endurance and activity tolerance. So you can do this in a functional occupation-based context. Are clients able to perform a task in a reasonable amount of time with or without rest breaks or loss of breath, shortness of breath? There are some standardized measures. So the rate of perceived exertion, or the RPE, measuring activity tolerance. So how hard are you working? Very light, light. There's a whole host of different types of rate of perceived exertion scales, depending on where you work. But take a look at, you can find a bunch on the internet, 1 to 20, whatever. There's lots of scales for the RPE scales. And MET levels, these are must know. These are the energy costs of an activity. So if you look in your Pedretti, you will find a MET level scale. And this is really important specifically with your cardiac clients. So this is the amount of energy it costs somebody to complete a task. And it's determined by the amount of oxygen that is required. So if I'm sitting here quietly doing nothing, I'm using 1 MET level. 1 MET is equal to 3.5 milliliters of oxygen. All activities above 1 MET are multiples of the resting rate of oxygen consumption. So for example, weeding the garden equates to 2 METs, as it requires twice as much energy than at rest. So MET levels, super, super important to know. And something to consider in terms of activity tolerance, endurance, MET levels, when one is not targeting increasing MET levels or energy levels, our clients are losing muscle mass. So each day a client is in the bed, they lose 15% of muscle mass, and this can be improved with early mobilization and exercise. So just think about that. Just right challenge. How do you challenge your client to improve their MET level, their activity tolerance, within what they're able to do? So a whole host of resources for you related to MET levels. MET levels. So MET levels are important with your cardiac clients. It's important to know what MET level they're at, so how you can challenge them. And it is important to challenge them within that MET level. It's important for you to know what the signs and symptoms of cardiac distress are if they've gone beyond that. And that could be shortness of breath or dyspnea upon exertion. That could be angina or chest pain. That could be increased heart rate, changes in blood pressure. For your cardiac client, precautions, sternal precautions, keep your move in the tube. We'll talk more about that in your intervention class, but that's part of your education with your cardiac client and considering how you're going to document all of that. So for this lab, you're going to do an evaluation of an outpatient. So the things that you must consider is always washing your hands, checking your client's ID, make sure you're treating the correct person, checking vital signs, blood pressure, heart rate, O2, always doing your pain assessment, and make sure they have safe footwear and a gait belt on. These are eval must-dos. This is safety, safety, safety. So now you've got all your data. You've documented all of your data. You've documented that you use the volumeter. These were the results, and this is why it matters. You documented sensation. You documented that you did the monofilament testing. These are the results. This is why it matters. Now you need to take all of that data and synthesize it, and analyze it and synthesize it. So what did they do and how did they do it? Why do they need your specific skilled intervention? How do you justify the continuation of OT services? So this is the assessment of that data. Your assessment must include limitations, their ability to make progress, and their potential. So what did they do? How did they do it? And why do they need you? This is something to consider with devising your problem, your barriers or your problems. What are the contributing factors? What are the performance skills that are a barrier to the client? How does it impact them and their ability to engage in occupation? How does their personal factors contribute to and impact how they present and their ability to engage in occupation? So as you are devising your assessment, what is the contributing factor that impacts how they present to engage in occupation? And this should start to feel pretty familiar at this point. As you're doing your evaluation, you also want to identify what are their strengths and how will their strengths support progress. And this is so important when you develop your intervention plans in the fall. So you need to have a clear idea of what the problems are, what are the contributing factors, performance skills, body functions, body structures, client factors, how it impacts how they present, and their ability to engage in occupation. And also, what are their strengths? Because this will support how you then devise your intervention plan and help them meet goals. Why do they need you? I think we've talked a lot about that. So this is actually one of the clients that you will be working with this weekend. So as you create a plan, you need to know what the length of stay is. The case study for Christy specifically gives an order of 3 times a week for 4 weeks. You will write goals, and you need to come up with a discharge plan. Where are they going after they see you? Giving them home exercise program, recommending equipment, and doing education and training. You must document all of these things. Goal writing, this should also look pretty familiar. SMART goals: specific, measurable, achievable, relevant, related, time limited. So they have to be significant to the client, client-centered and occupation-based. They need to be measurable. How are they measured? In terms of assist level, specific conditions. Are they achievable and realistic? Are they relevant and customized to the client? Are the goals related to each other? So you might have 5 long-term goals, and each short-term goal you write needs to be related to that specific long-term goal. And how long will it take them to meet that goal? And by discharge is not cool. Do not tell me by discharge. So here's an example of an assessment. So the client had an ORIF of the right distal radius. I had a brain fart for a second. Open reduction, internal fixation of the right radius. So some sort of internal fixation of a radial fracture. She presents with decreased range of motion, decreased strength, decreased fine motor coordination, decreased sensation, increased pain and edema in her right hand. They're impacting her ability to perform ADLs, IADLs, return to work. She is motivated. She's able to participate fully. She will benefit to address these functional deficits, and her plan of care is 45 minutes a day, 2 to 3 times a week, based on the Christie case study for 4 weeks. And we stress to be very specific. So maybe my assessment here isn't specific enough, and you're like, but what about, you're absolutely right, decrease calibration of grip, decrease reach, decrease specific range of motion at her shoulder, decrease pain or increase pain during mass grasp, decrease pain or increase pain during fine motor manipulation pinch. So getting very specific with what her barriers are. And then some goals for this client. I'm not going to read these to you, but they'll be in your resources. So these are some goals that you could use as a guide when writing outpatient goals or more biomechanical type goals. Okay. So that is prep for the next upcoming lab. I hope this was helpful, and don't hesitate to reach out with questions.